But the parts of the nephron can be very, very, very difficult for us to remember. So the way to remember the parts of the nephron is by looking at a roller coaster. A, B, C for sympathetic inhibitors. So we have alpha blockers, beta blockers, alpha plus beta blockers, and centrally acting. She is going to get calcium channel blockers or thiazide diuretics. She is going to get ACE inhibitor or ARB. So for ACE inhibitor. And welcome to Dr. Mira Teaches. We'll be looking at antihypertensive medications. Now, let's do a brief recap. We remember that from our previous videos, we have seen that hypertension is due to factors that will either activate the sympathetic nervous system, the renin-angiotensin aldosterone system, or factors that increase the individual components of the BP equation. All right, so if you want to increase your blood pressure, you either increase cardiac output or increase systemic vascular resistance. We saw that both the sympathetic nervous system and the renin-angiotensin aldosterone system lead to vaso increased systemic vascular resistance by causing vasoconstriction. However, the way that the increased cardiac output differs, okay, we saw that the sympathetic nervous system causes the heart to beat faster and harder. Okay, so it increases heart rate and stroke volume. That's how the sympathetic nervous system increases cardiac output. It does so by focusing on the heart. It makes the heart to beat faster and harder. But the renin-angiotensin aldosterone system focuses on the kidney. All right, it causes salt and water retention. Okay, so that is how the renin-angiotensin aldosterone system lead to an increase in cardiac output, okay, by causing salt and water retention. So if you want to decrease BP, then you have to do the opposite, isn't it? You would have to block the sympathetic nervous system and then the renin-angiotensin aldosterone system. When you block the sympathetic nervous system and the renin-angiotensin aldosterone system, you can decrease systemic vascular resistance. So instead of vasoconstriction, you achieve vasodilation. Okay. If you also want to decrease cardiac output by blocking the sympathetic nervous system, you will decrease heart rate and stroke volume. That's where you can decrease the cardiac output. Same for RAS. All right. You prevent salt and water retention and thereby decrease cardiac output. Okay, so if you want to decrease BPs, either you decrease the individual components of the BP equation, which is cardiac output and systemic vascular resistance, or target these two systems, the sympathetic nervous system and the renin-angiotensin aldosterone system. Okay, so we have five targets. If you really think about it, we have five targets to help us bring down the blood pressure. And these five targets are based on the BP equation. Okay, you can either reduce the systemic vascular resistance or decrease cardiac output, decrease both cardiac output and systemic vascular resistance. Or you target the systems, which are the renin-angiotensin aldosterone system and sympathetic nervous system. These two will decrease both cardiac output and systemic vascular resistance. All right. Okay. So these are the medications, all right, that act on these five targets. So we have sympathetic inhibitors, RAS inhibitors, calcium channel blockers. You see that they are neither sympathetic inhibitors or RAS inhibitors, but they can block both the cardiac output and systemic vascular resistance to help bring down BP. All right. Then we have diuretics, which targets cardiac output, and vasodilators, which targets systemic vascular resistance. Okay. So we've seen five targets. So let's look at medications under these five targets. Okay. So for sympathetic inhibitors, the way to remember it is by using ABC. Okay. ABC for sympathetic inhibitors. So we have alpha blockers, beta blockers, alpha plus beta blockers, and centrally acting. Okay, so these are sympathetic inhibitors with A, B, C's, alpha blockers, beta blockers, alpha plus beta blockers, and then centrally acting. Okay, so alpha blockers, we have terazosin, all right, terazosin. Okay, there are other alpha blockers like tamsulosin, which is used in prostate disease, BPH specifically. Okay, but that one does not bring down the BP. All right, so this one does terazosin. Okay, then we have beta blockers. For beta blockers, we have selective and non-selective. All right, the selective ones, they work directly on the heart, just on the heart. Okay, so atenolol, bisoprolol are selective. Atenolol, bisoprolol are selective. But the non-selective beta blocker is propranolol, which is a mouthful. So it works not just on the heart, it works on other beta receptors in the body. All right, so propranolol is non-selective. Please remember, propranolol is non-selective. Okay, then we have, so if you look carefully, you realize that beta blockers end with LOL, LOL, LOL. All right. But then we have alpha plus beta blockers. Okay. And they also end with LOL. So you shouldn't be confused. The famous carvedilol and labetalol are not just beta blockers. They are alpha and beta blockers. So always remember we use labetalol for the labetalol protocol in our emergencies. Okay. And carvedilol is also used especially with heart conditions. All right. So alpha plus beta blockers, carvedilol, labetalol. They are not just beta blockers. Okay. Even though they end with LOL. So please keep that in mind. Then we have centrally acting, which is methyl dopa. Okay. So we have covered sympathetic nervous system inhibitors, using A, B, C. Okay, now let's go to the renin angiotensin aldosterone system. All you have to do is inhibit the individual components within the system. Okay, so you want to inhibit renin, you want to inhibit angiotensin 2. Remember, it's angiotensin 2 that does the work. Okay, that's what does the vasoconstriction. You want to inhibit angiotensin 2 and you want to inhibit aldosterone. Okay, so for renin inhibitors, we have aliskiren, right? Then for angiotensin 2 inhibitors, we have angiotensin converting enzyme inhibitors. Okay, so ACE inhibitors. What are ACE inhibitors? Remember that angiotensin 2 is originally angiotensin 1. Okay, but angiotensin 1 is not what does the job, it's angiotensin 2 that is powerful. All right, so we need to convert angiotensin 1 to angiotensin 2. And then it is the angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. So to prevent angiotensin 2 from forming, we can inhibit the angiotensin converting enzyme so that the angiotensin remains as angiotensin 1 and just stays there. Okay, so lisinopril, ramipril, captopril, all the prils are ACE inhibitors. Okay, once you inhibit ACE, you don't have angiotensin 2 forming. Okay, now we can also block the angiotensin receptor blockers. We can also block the angiotensin receptor. Okay, we can block the angiotensin receptor. Once you do that, angiotensin 2 cannot bind, and then you do not form, you are not able to achieve vasoconstriction that occurs with angiotensin 2. Okay, so we have angiotensin receptor blockers. These are losartan, candesartan. So all the sartans are angiotensin receptor blockers, ARBs. Okay, so we have two things that can inhibit angiotensin 2. Okay, then the next A is aldosterone. All right, aldosterone inhibitors or aldosterone antagonists. We have spironolactone and eplerenone. Look at the ending of the aldosterone, ONE. Okay, so spironolactone, ONE, eplerenone, ONE. So that's it follows the name of aldosterone. So aldosterone antagonist. Okay, then we have calcium channel blockers, which are commonly used here. We have dihydropyridine calcium channel blockers, which target blood vessels. All right, they are specific for blood vessels. We want vasodilation instead of vasoconstriction so that we can bring down systemic vascular resistance. So we use amlodipine, nifedipine, felodipine. Okay, this is what we commonly use here in Ghana: amlodipine, nifedipine, felodipine. These are dihydropyridine calcium channel blockers. Okay, you see that DI, you have DI in amlodipine, you have DI in nifedipine, you have DI in felodipine. All right. Then we have the non-dihydropyridine calcium channel blockers, which work on the heart. Okay, they help to reduce the contractility of the heart. So we have verapamil and diltiazem. Now the thing about calcium channel blockers is that calcium in itself helps with vasoconstriction and also heart contractility. Do you see? So once you block calcium, you prevent or you help to reduce vasoconstriction and you help to reduce the strength at which the heart is going to contract. Okay. So the dihydropyridine ones reduce calcium block calcium channels within blood vessels, while the non-dihydropyridine calcium channel blockers block calcium channels in the heart. Okay, so that's it. So always remember that calcium channel blockers, we have dihydropyridine and non-dihydropyridine. All right, depending on the target of the calcium channel blocker. Okay, then we have diuretics. Diuretics, there are quite a number. All that diuretics do is to let you lose salt. Okay, once you lose salt, water will follow, and then you bring down the cardiac output. Okay, once you lose salt, water follows and you bring down the cardiac output. Now, there are several diuretics. Okay, there are several diuretics, but this tutorial is focused on diuretics that we commonly use for hypertension. Okay, now the way to remember diuretics is to look at every single aspect of the nephron. Okay, diuretics work on the kidney. They let you lose salt so that you can also lose water and then you can bring down your cardiac output. Okay, but the part of the nephron can be very, very, very difficult for us to remember. So the way to remember the part of the nephron is by looking at a roller coaster. The nephron really is a serious roller coaster ride. Proximal convoluted tubule and the distal convoluted tubule. These are the two parts that will make you go crazy and want the ride to end. Okay. So in between these two parts, the ride gets easier. Okay. So you start from the Bowman's capsule, you come to the proximal convoluted tubule. Oh my God, can we stop this ride? I can't do this anymore. Then it comes to an end, you're like, thank God. Then you descend to the roller coaster. That's the descending loop of Henle. Okay. Then just when you think everything is about to end, you ascend again through the ascending loop of Henle. Okay, then you go through another crazy ride at the distal convoluted tubule, and then finally come to an end through the collecting duct by descending. You see, so that's how you can remember the parts of the nephron. Okay, now when it comes to diuretics, diuretics work at different places. They work here, they work here, they work everywhere. All right, but when it comes to hypertension, we just want to look at three main diuretics. Okay, you want to look at the ones that work from the ascending loop to the collecting duct. So we are starting from here. Okay, so the first one is the loop diuretics. Okay, loop diuretics, that is furosemide. So furosemide works on the ascending limb of the loop of Henle. Okay, then when it comes to the distal convoluted tubule, you have the thiazide diuretics. Okay, thiazide diuretics work over here. So thiazide diuretics and thiazide-like diuretics, they work at the distal convoluted tubule. Then when you come to the collecting duct, we have spironolactone, okay, which are the aldosterone antagonists. Okay, so they work at the collecting duct. Now, at the ascending limb of the loop of Henle, we lose sodium and potassium. At the distal convoluted tubule, we lose sodium and potassium. However, at the collecting duct, you only lose sodium. Okay, so furosemide and thiazide or thiazide-like diuretics make you lose both sodium and potassium. But the collecting duct, that's spironolactone, you only lose sodium. So we've seen this, that for diuretics at the loop of Henle, the ascending loop of Henle, we have furosemide where you lose sodium and potassium. Okay. Then we come to the distal convoluted tubule. Okay, where we have the thiazide diuretics like bendroflumethiazide and the thiazide-like diuretics, like in dapamide. All right, so bendro, flumothiazide, all the other ones with flumothiazide, thiazide, those are the thiazide diuretics. Okay, so thiazide diuretics and thiazide-like diuretics, you lose both sodium and potassium. Furosemide, you lose sodium and potassium. Okay, however, when it comes to spironolactone, the only salt you lose is sodium. Okay, you only lose sodium to get water out, okay, of the nephron. That's how diuretics bring down your cardiac output. Okay, when it comes to vasodilators, that means that they are working on reducing systemic vascular resistance. We have arteriolar vasodilators and we have arteriolar plus venodilators. So these work on arterioles and venules. But here we have those that work only on arterioles, all right, on the arteries. So that is hydralazine. All right, hydralazine is an arteriolar vasodilator. So commonly we've seen hydralazine a lot of times in our emergency. It will just works by dilating the arteries. But then nitroprusside, okay, works on both veins and arteries. All right, so these are the five main classes of antihypertensives. Vasodilators reduce systemic vascular resistance, diuretics reduce cardiac output, calcium channel blockers reduce systemic vascular resistance and cardiac output. All right. Then you have renin, angiotensin, aldosterone system inhibitors, which reduce both cardiac output and systemic vascular resistance. Sympathetic inhibitors also reduce cardiac output and systemic vascular resistance. Okay. So we've seen a lot of medications, but how do we know which one to begin with? Okay, usually you want to begin with one medication if it's straightforward hypertension, no complications, no comorbidities. You just want to start with one medication. All right. Now, for your first line, for monotherapy, you need to consider the race of the individual. Okay. Usually for Africans, we it's been shown that calcium channel blockers and thiazide diuretics are better work better in Africans. They work better to bring the blood pressure down in Africans. All right. So calcium channel blockers and thiazide diuretics. So if an African comes to you in your clinic, all right, we want to give calcium channel blockers like amlodipine, ifedipine, etc., or thiazide diuretics like bendroflumethiazide. All right, so that's why commonly when patients come to you in the clinic, they are on it's either they're on amlodipine or they're on bendro, all right, because it's been shown that that's what is good for us as Africans. Okay, however, if the person is a Caucasian, all right, if the patient comes to you, you want to start the patient either on an ACE inhibitor or an ARB. All right, so she is going to get calcium channel blockers or thiazide diuretics. She is going to get ACE inhibitor or ARB. So for ACE inhibitor, you can give lisinopril, all right, lisinopril and all of that. But ARBs, you can give losartan, candesartan. Okay. Then when do we do two medications? Because we see that it's not all the time that the patient is on one medication. There are times where the patient is on two medications. You put a patient on dual therapy if the patient's BPs were not controlled on one. All right, so you want to add a second. Okay. And the other reason why you put the patient on dual therapy is that maybe the patient comes to you. The first time the patient is presenting, the BPs are already shooting to the skies, more than 180, 110. The person has entered hypertensive emergency or hypertensive urgency. All right, the person is in hypertensive crisis. Okay, so that is when you straight away start with two antihypertensive medications. Okay, so these are the two main conditions according to the standard treatment guidelines when you want to start a patient on dual therapy. Okay, so how do you know which medications to add? You need to know the first line antihypertensives that we use. Okay, we've already seen some. We've seen ACE inhibitors, ARBs. We also saw calcium channel blockers and thiazide diuretics. The only addition is beta blockers. Do you see? It makes it very simple. ACE inhibitors, ARBs, we've seen that, and we usually give to Caucasians. We saw calcium channel blockers and thiazide diuretics, which we give to Africans, and then beta blockers. So A, B, C, D. That's how you remember them. So if the person is an African, comes to you the person was already on one medication, say a calcium channel blocker like amlodipine, you've checked maybe after 3 months, BPs are not dropping. You want to add on a thiazide diuretic. All right, okay, because the person is an African, if the person is a Caucasian, you want to do ACE inhibitor or ARB. All right, so it depends. Okay, so you need to look at the situation and decide which add on you are going to choose. Okay, but you can't just add on medications without considering the fact that certain comorbidities may be present. If everything is straightforward, you can go by the rules we've already spoken about, but there are issues. Things are not always as straightforward as they seem. Okay, patients may come with other underlying conditions or even complications of hypertension. All right, and you need to, and that may inform your choice of antihypertensives. All right. So, in the presence of left ventricular hypertrophy, you want to give ACE inhibitors or ARBs. Now, you'll see that this list looks long and the medications seem to be a lot. All right, there seem to be many within this list. But I want you to hold on for a second. Don't zone out because I'm going to drive at a point that will help you to remember which medications you can use for when there are comorbidities present. Okay, so just hold on, just a little tiny, any winning little bit, and let's see. All right, so what do we see? There is a pattern. You realize that for every single condition listed here, you either use an ACE inhibitor or ARBs. ACE inhibitor, ARB. Microalbuminuria, ACE inhibitor, ARB. Renal dysfunction, ACE inhibitor, ARB. Previous stroke. It says any of the first line drugs, especially ACE inhibitor. Coronary artery disease, ACE inhibitor, ARB. Heart failure, ACE inhibitor, ARB. Peripheral artery disease, ACE inhibitor, ARB. Of course, there's calcium channel blocker, right? Diabetes mellitus, ACE inhibitor, ARB. Atrial fibrillation, ACE inhibitor, ARB, or beta blocker. So the point I'm trying to drive at is if you observe carefully, if you look at the pattern, ACE inhibitors or ARBs are generally preferred in the presence of other comorbidities. Okay, and ACE inhibitors and ARBs are known to be cardioprotective and they also renal protective. So they protect the kidneys, they protect the heart. Okay, so they are generally preferred. Okay, so if you are confused, if there is a comorbidity, you generally want to begin with an ACE inhibitor or an ARB, right? When there are comorbidities, that's what you should be thinking about. You see, it's very simple. Okay, but you also have to bear in mind that there are contraindications to antihypertensive medications. For ACE inhibitors or ARBs, which is what we just looked at, remember hyperkalemia and bilateral renal artery stenosis. So when there is hyperkalemia and bilateral renal artery stenosis, please, please, please don't give an ACE inhibitor or an ARB, please. All right, you can't give a calcium channel blocker in heart failure because you further weaken the already weak heart. All right, remember the calcium channel blockers block calcium channels. All right, so if calcium channels are blocked, the heart can't beat as strong as it would have. Okay, but the heart is already failing and you don't want to worsen that. So please, we don't give calcium channel blockers in heart failure. We don't give beta blockers in asthma. Everybody knows this. Don't give it in asthma. You're going to trigger an asthmatic attack and you can be in trouble for doing that. So please do not give beta blockers in asthma or second and third degree AV block. And remember that thiazide diuretics prevent the excretion of uric acid. All right. So the more uric acid you have in your system, the more you worsen gout. Okay, you make gout worse. All right. So please, when the patient has gout, don't give thiazide diuretics. All right. So these are compelling contraindications that you must be aware of. Okay. Now, we've seen oral medications. When do we do the parenteral medications? When do we do the medications that you give IV? All right. Usually do them in hypertensive crisis where BP is greater than 180, 110, 120 millimeters of mercury. Okay. During hypertensive crisis, we don't want to give short-acting nifedipine. Why? It lowers the BP too rapidly. You bring it down too fast. Okay, once you bring the BPs down too quickly, you cause ischemia of vital organs because now the blood flow, right, to the vital organs reduce significantly, all right, and you rather cause issues. You wanted to save the patient, but now you are causing ischemia to the vital organs like the brain, the kidneys, the heart. So please don't give short-acting nifedipine when a patient's BP is over the roof, like greater than 180, 110. You cannot do that. All right. What you want to do is to do parenterals. All right. You want to give you want to do your labetalol protocol or your hydralazine protocol if you cannot do labetalol. So IV labetalol 20 to 50 milligrams start is what you give. So you draw 20 to 50 milligrams start. Then you need to give it slowly over 2 minutes. So you realize that in the emergency, anytime the nurses are going to administer IV labetalol, they take a chair and sit by the patient and push it in through the IV line very slowly. All right, very slowly. So you're supposed to do this over 2 minutes. Okay, so 20 to 50 milligrams of labetalol slowly over 2 minutes, and you can repeat it at 10 minutes interval. The maximum dose is 200 milligram. All right, so that's it. The difference between labetalol and hydralazine is that for hydralazine, the dosage is different. It's a lower dose, 5 to 10 milligrams, slowly over 2 minutes, same process. You sit by the patient, push it in slowly, but the interval at which you repeat is 20 to 30 minutes. All right, so you need a larger interval a longer interval to repeat your hydralazine, and the maximum dose is also 200 milligram. Okay, so please take note. And you want to lower the BPs gradually, not more than 25% within the first hour. Lower the BP gradually, not more than 25% within the first hour. So for example, if a patient comes to you with a BP of 200, the patient comes to you with a BP of 200 millimeters of mercury for systolic, all right, 25% is actually 25 over 100, which is 1 over 4. All right, 1 over 4. So 1 over 4 times the patient's systolic blood pressure, which is 200. Okay, and that will give you 50. All right, that will give you 50. Remember, 4 will go here, 1. Let's do some math. 4 here, 1. 4 will go here. 4 into 25, 4, 5, 20. So 5, and then you add your 0, 50. All right. So what you have is 50 millimeters of mercury. Okay. So it means that you don't want to drop the BP by more than 50. Okay. So 200 minus 50 will give you 150. So that will be your benchmark. That will be your benchmark. 150 millimeters of mercury will be your benchmark. So we do not want to drop a patient's BP um, by more than, so we don't want the patient's BP to go below 150 in the first hour. So that first hour is where you do the slow dip. The first hour when the patient presents is when you do the slow dip by not more than 25%. So you just calculate 1/4 of whatever BP the patient comes with. All right. So if you get 50 milligrams, you subtract it from the patient's BP, and that the value you get will be the benchmark, okay, by which you wouldn't want to go below. All right. And remember that you need to check your patient's BP every 5 minutes, every 5 minutes to see what exactly is happening. So, so this is just a brief summary for what we've said so far. Calcium channel blockers and thiazide diuretics should be used for blacks. ACE inhibitors, ARBs for whites. ACE inhibitors or ARBs are generally preferred when there are comorbidities. Okay, they are generally preferred. It doesn't mean that you cannot use other antihypertensives. Okay, it's just a pattern that we have noticed. All right. So because we know that these ones are cardio and renal protective, you have to remember your contraindications. All right. And we don't want to give nifedipine in hypertensive crisis. These are the management rules. Okay. So thank you very much for watching. I hope it was helpful. I hope you understood. I hope you'll be able to know which medications to prescribe for your patients. Okay. As always, keep studying, keep shining, keep learning, and glow like the African sun. Bye.